When President Ibrahim Traoré approved a $60 million shift in national spending, it wasn't for walls, weapons, or even hospitals. It was for buses. With a single stroke of a pen, he launched what would become the largest mobile healthcare operation in Burkina Faso's history. The mission was simple yet extraordinary: to reach the people who had been unreachable for decades. In a nation where nearly one-third of the land has never seen a clinic, where entire provinces have gone more than 10 years without a doctor, and where women still give birth in the dark without trained help, this new vision was nothing short of revolutionary. Too many lives had already been lost, not because of poverty alone, but because of neglect, because there were no doctors, no phones, no transport, and no time. Now those white-painted buses roll across the countryside, solar-powered and fully equipped, staffed with trained nurses who bring checkups, medicine, and emergency care to forgotten communities. These vehicles are not symbols of charity. They are instruments of justice. For the first time, remote villages see dignity arrive on wheels, carrying not just hope but real medical support. Imagine your own mother deep in the bush having a seizure with no doctor in sight. Imagine the helplessness. That was the reality Traoré sought to change. The decision did not come with fanfare or televised speeches. It was a quiet act of redirection, taking money once reserved for military recovery, drought relief, and debt emergencies, and channeling it into something no strategist expected: health on wheels. The budget order was signed under a presidential clause allowing emergency discretion. For Traoré, the emergency was clear: people were dying from conditions that could be prevented or treated. When the initiative was first presented inside the presidential compound, the atmosphere was tense. Generals and security officials had gathered, expecting funding for drones, cyber defense, or border reinforcements. Instead, they were shown blueprints for buses converted into mobile clinics. A senior commander from the Sahel front spoke first, warning that the north was still unstable and that this was no time for social experiments. Another official complained about neglected airfields and fuel shortages. Why? They demanded, would the president prioritize buses? Traoré's answer was calm but firm. Every nation chooses what it calls sacred. You invest in borders, but I will invest in breath. A country without clinics is not a nation, it's a graveyard in the making. His words cut through the room. There was no applause, but also no rebuttal. Something irreversible had begun. Soon after, the Ministry of Transport received an unexpected order. 220 decommissioned buses from state storage lots would be reclaimed, refurbished, and converted into mobile clinics. These were not shiny new imports, but old vehicles, some abandoned since 2015, some stripped for parts, others left to rust. Yet, under Traoré's directive, they would be reborn with a new mission: not to carry passengers, but patients. Floors were reinforced, electrical systems rewired for off-grid use, and interiors redesigned to handle surgical equipment. Overhead, bright LED lamps were mounted, strong enough to light emergency procedures at night. Refrigeration units were installed to store blood, insulin, and vaccines. Even waste disposal systems were built in, compressing and sealing hazardous material on the spot. Each bus became a self-contained medical center, running entirely on solar energy, capable of operating for 7 days straight without outside power. Refrigerated cabinets could withstand the jolts of rough dirt roads, while medicine drawers were secured with biometric locks. On-board labs carried rapid malaria kits, blood pressure monitors, and ultrasound devices. By the time the first fleet rolled out, each bus carried over 450 pieces of medical equipment, ready for fieldwork in some of the harshest conditions in West Africa. The numbers behind the initiative were staggering. Each vehicle was expected to serve up to 3,000 citizens every month, staffed with rotating doctors, trained nurses, and technicians capable of handling portable diagnostics. The teams became lifelines for regions long forgotten. These weren't outsiders flown in on contracts. Most were local professionals who spoke the languages of the villages and understood their struggles firsthand. Of course, critics called the plan reckless, unrealistic, and unsustainable. But as more buses rolled out, villages began to see the difference. Children came forward with skin infections that had never been treated. Elders checked their blood pressure for the first time in a decade. Women learned they could get tested for infections without walking 2 days to the nearest provincial capital. And then came the births, hundreds of them, safe deliveries that once would have been impossible. In just the first 90 days, more than 13,000 people had been registered and treated. Among them were men with untreated wounds, children suffering from parasites, and women diagnosed with hypertension for the first time. But most remarkable of all, 740 babies were delivered, not in darkness or isolation, but safely, inside buses turned into lifelines on wheels. The births that took place inside those converted buses were nothing short of miracles. These were high-risk emergencies, handled in cramped compartments, often by torchlight when storms drowned out the solar panels. There were no epidurals, no modern operating theaters, just human skill, sterile trays, steady hands, and whispered prayers. How many of those women would have lost their lives waiting for an ambulance that never comes? How many newborns would have drawn their first breath only to choke in silence, denied oxygen, denied help? 3 months after the launch of the first Light mission, the initial wave of national health data reached the president's desk in Ouagadougou. The numbers didn't speak softly, they shouted. In the provinces where mobile clinics were deployed, malaria-related deaths had fallen by an astonishing 62%. The figure, confirmed by Burkina Faso's own Institute for Public Health, wasn't speculation. It was fact, proof that early testing, rapid treatment, and most importantly, access were rewriting the story of survival. For the first time in years, people were receiving care at the first sign of illness, not when they were too weak to walk or when fever had already stolen their sight. But the numbers only told part of the story. In Xilga, a young mother named Alimo learned how to purify water with chlorine tablets, not from a foreign aid worker, but from a nurse inside a converted bus parked beneath the trees of her childhood village. Before that lesson, her child suffered monthly bouts of diarrhea. Since then, he hasn't fallen sick once. In Kumbasari, a teenage boy learned to clean wounds with boiled water and antiseptic. Before that, he had been using engine oil. These were not surgical miracles. They were small, practical lessons, delivered in familiar language, rooted in trust. For too long, remote communities had been written off as unreachable. Now, education and care arrived directly in their courtyards. Nurses described their mission not simply as treatment, but as teaching people to unlearn fatalism. Instead of silence and resignation, they planted new habits, washing with clean water, disinfecting wounds, recognizing danger signs. How do you measure the moment when a grandmother stops pouring kerosene on injuries and begins using sterile cotton? These weren't statistics. They were transformations of belief. In Tanger, one of the later regions reached, an innovation appeared on the wall of an old school. A laminated health board, satellite-linked and updated weekly in 3 languages. It listed malaria cases, maternal complications, TB alerts, vaccination counts, even water test results. For the first time, villagers saw their health tracked in real time, their struggles mapped and connected directly to the Ministry of Health. They were no longer invisible. Fevers were no longer just memories or unmarked graves. They were entries in a system that finally acknowledged them. This wasn't infrastructure of cement, but infrastructure of connection. And the greatest shift wasn't in charts or data, but in dignity. Where people once accepted sickness as destiny, they now asked questions. They learned what a diagnosis meant, which pill treated which condition, and they began to demand answers. What happens to a nation when its people stop believing death is inevitable? What cracks open inside a system when citizens expect survival instead of surrender? The first Light mission was never intended to be permanent, but permanence had never saved lives. Presence had. And in villages where maps once showed only forests, the presence of care was drawing new lines. Not borders of land, but borders of belief. By mid-year, the program could no longer be contained within Burkina Faso. What started as an emergency plan became a regional spark. Within weeks, neighboring governments sent delegations to study the buses. Niger moved first, signing a joint agreement in Niamey to launch a pilot with 20 vehicles modeled on Burkina's blueprint. Their health minister made it clear, this is not charity. This is intelligence, and we need it. Soon after, Togo requested schematics. Mali followed, asking to observe deployments in Kudugu and Hound. Within 2 months, 3 nations had joined what became known as the Mobile Equity Pact. This wasn't pushed by Western donors or international NGOs. It was African leaders learning from each other, replicating solutions born on their own soil. The momentum was undeniable. International headlines took notice. In France, one paper called Traoré, the General of Health. Another wrote, "For the first time, a patient in Burkina Faso goes to sleep with real hope of waking up alive." Across African universities, panels dissected the first light strategy as a public health model. In Nairobi, officials held calls with Burkinabe doctors to learn about logistics. Even in Senegal, where imitation is rare, a televised debate asked, "Why didn't we think of buses? How can a country rebuilding itself become a teacher for others?" Back home, the impact grew more personal. Children drew pictures of white buses with red crosses in classrooms. In Kaya, a barber taped Traoré's portrait beside his clock, saying, "It's time to heal." The streets did not erupt in chants, but whispers of legacy spread. Could a post-coup state truly lead the continent in medical innovation? And if so, what if that legacy wasn't built of stone, but of wheels? Not everyone celebrated. International coalitions questioned the scalability of the program. Think tanks in Europe doubted the accuracy of its data, warning it might collapse under its own ambition. But while critics debated, delegations kept arriving. Mali sent its second team. Guinea dispatched engineers. Sierra Leone offered refurbished ambulances. Uganda's medical journal dedicated an entire issue to the first light model, including a cover story titled "Decentralizing Care." The Burkinabe Blueprint. Visitors who came weren't met with glossy presentations. They were invited to ride along. They saw women in Namina receiving their first insulin dose in 7 years. They saw a child tested for malaria within 5 minutes of arrival. The silence that followed those moments was the only proof needed. At the African Union Summit in Addis Ababa, Traoré was unexpectedly added to a health session. Wearing his military uniform, carrying no notes, he spoke simply, "Justice must move. It cannot wait." For the first time, the hall rose to give a soldier a standing ovation, not for a military victory, but for a healthcare vision. By the year's end, 6 more countries had sent in queries, 3 ministries requested joint exercises, and 1 East African journalist captured the essence in a single line. Traoré did not begin a revolution. He resumed one long delayed. The first light mission was never just about buses or budgets. It was about belief turned into action. In a world that too often paints Africa as dependent, this was Africa writing its own prescription. Traoré's gamble proved that healing doesn't require permission, it requires intention. And if healthcare could move, what else could? Could justice roll to forgotten villages as medicine had? Could mobile schools carry education where textbooks never reached? Could courts on wheels resolve disputes in places no judge had stood? For decades, Africa was told to wait for aid, for grants, for mercy. But this story tells something different. Africa can act now, with its own hands, its own vision. As one villager said quietly while watching a white bus arrive, "We thought they forgot us." But they came. So what do you think? Would you trust Traoré's bold path or cling to the old ways, cement walls, foreign donors, and endless waiting? Share your truth. And if you believe in this journey of healing from within, then carry it forward. Because Africa has always known how to survive. It only needed the chance to move.